So my talk will be about the colorectal cancer, but in this case review, we'll be talking about a gentleman who has the metastatic colorectal cancer. So as we all know and we heard in the first session that colorectal cancer is one of the most common cancers both in the men and women, and the favorite sites to metastasize is the lung and liver. So up to one-fourth of the patient diagnosed with the colorectal cancer, they have the liver metastasis, and almost 50% of the patient, by the time they die, we find that they have the liver mets. The good thing in the liver and lung metastasis in the colorectal cancer, which we don't find in other solid malignancies, that the role of metastatectomy is well established. So there are a large number of studies which have defined the role of metastatectomy. Not only the safe, but we can do as with the curative intent also. So objective of my talk: patient with isolated liver or lung metastasis can still be treated with curative intent, and patient should be carefully selected. Like every week we have the GA tumor board, and whenever we take the patients to for discussion, 50% of patients are metastatic. So the first question, the general surgery, radiation oncology, and interventional radiology, whenever they offer the local therapy for these isolated liver or lung lesions, the first question always is that the primary disease is controlled or not. So primary disease control, good performance status, and the patient should have a good residual organ function. So if we are going to do any local therapy for the liver or lung lesion, so there should be an adequate reservoir who can, so the patient can maintain his functions post-operatively. So my case is about a 45 years old gentleman for which I have to go back to 2007 when this gentleman was presented to our hospital with the PR bleeding, and he didn't have any medical or surgical history, neither he had any family history of malignancy. So colonoscopy that time it was done, which showed that he has a tumor 10 centimeter from the anal verge. Biopsy was taken and it showed that it was moderately differentiated adenocarcinoma. CEA level at that time was 21. The CT scan, staging CT scan, that time it didn't show any metastasis. So the patient was so MRI showed that the patient has a posterior rectal wall mass. It was 3.5 into 1.5 centimeter and reaching up to the perirectal fat. So T3N1 M0 was the TNM staging at that time. So as per standard, he received the neoadjuvant chemotherapy with radiotherapy. It comprises capecitabine with radiotherapy for 5 weeks, followed by in January 2008, he had the lower anterior resection. It was 1.5 centimeter of tumor. One out of the 5 lymph nodes were involved by the tumor, and the stage was T3 and 1 in MX. So we offered the patient adjuvant chemotherapy, which is the Xelox, capecitabine with oxaliplatin, and he completed the treatment until September 2008 without any significant toxicity and with reasonable tolerance. After that, almost 8 months from the last cycle of Xelox chemotherapy, the follow-up CT scan of the chest, abdomen, and pelvis on the 1st of June 2009 showed that the patient has the liver lesion in the segment 6 and segment 7. So initially it was T3N1M0, and we have given the neoadjuvant chemotherapy followed by the surgery, and he received 6 months of adjuvant therapy. So 8 months after the adjuvant therapy, the patient is presenting with the liver lesions, and the rest of the scans were negative for the metastasis. So what should be our next step? Either we should go back and take the biopsy for this liver lesion. Should we offer any local therapy like surgical resection versus radiotherapy, or should we start with the systemic chemotherapy? So we taken the patient to the tumor board, and the consensus of the tumor board was the surgical resection of the tumor. Surgical resection was done, and we achieved the clear margin. It was colorectal adenocarcinoma, moderately differentiated. So he started the follow-up, and later on in September 2009, the CT scan of the chest, abdomen, and pelvis showed that the patient has right lobe 8 into 8 millimeter lesion with the CEA at that time was 11. Chemotherapy that time was started comprising irinotecan with capecitabine and Avastin until May 2010. So in the June, the CT scan was it showed that disappearance of the liver lesion. CEA was 1.37, and the patient was given the chemotherapy holiday. He was in good shape. Performance status was excellent. There was no toxicity. After like 3 months from his last cycle of the chemotherapy, which was in the metastatic setting, the patient showed up, and the scans showed that he has two more liver lesions, again in the segment 6. So again, this is the second time the patient has the metastasis in the liver, and the only side of the liver, metastasis was in the liver. Rest of the scans were negative. So again, we taken the patient to the tumor board. We discussed, and resection was offered in April 2011. The pathology again was consistent with the metastatic moderately differentiated adenocarcinoma. These are the slides of the resected liver lesions. So after 3 months of the uh, second resection of the liver lesion, the patient was again followed up with the scans, and the follow-up scan showed that the patient now, the liver was clear, and he didn't have any other evidence of the radiological evidence of disease, but the lung was showing that he has the lung metastasis at that time. So chemotherapy was offered to the patient. As we mentioned, that the patient was KRAS was wild type. It was cetuximab with irinotecan, and he continued from the June to October with a good tolerance. And PET CT scan in October 2012 showed that there was a response bilaterally. The liver lesion, lung lesion was smaller when compared with the scan which was done in June 2011. So after the shrinkage of this liver lesion, the case was discussed in the tumor ward. The patient was having only these two liver lesions, lung lesions, and no other evidence of the disease, good performance status. The tumor board, they offered the bilateral metastatectomy for the lung lesions. We offered this option to the patient. He opted to go to USA. So he went to the Fox Chase Center and received the same type of the treatment. He underwent the resection of the lung lesions, and they started on the Folfox and Avastin that time. So he remained stable till November 2014 when he developed the disease progression mainly in the lung. So this is the PET scan in November 2014 with two main lung lesions. This was the second time he has the lung lesion. Previously, the two-time liver lesion, one-time lung lesion was locally treated with the chemotherapy systemically. Chemotherapy fall free with cetuximab he received until March 2015. So went back to the Fox check, and cetuximab was dropped from the fall free and cetuximab protocol. Uh, we couldn't find any obvious reason. The molecular profiling at the Fox chase was similar as in our hospital. So on 21st of July 2015, he had PET CT scan, and it showed that there is disease progression. So USA, they added the Western bevacizumab with the FOLFIRI, which ended up with the rectal fistula, intestinal perforation, and prolonged ICU admission. During all this period, which is almost 2 months, 2 to 3 months, so the one of the liver lung lesion was increasing in the size, and he received the stereotactic radiotherapy for that. After that, patient continued his follow-up until August 2017. So he was doing well until he presented now recently in August 2017 last year with a left knee pain. So when we investigated initial X-ray, MRI, and the bone scan showed that he has the lesion in the distal femur, which was involving his left knee joint. It showed uptake on the bone scan. At that time, the CT scan did not show any other disease, but there was increase in the size of the lung nodules. But patient was offered the resection of the tumor at the distal femur, and also prosthesis was placed. At that time, patient was started again on the folfirinoximab. He is still receiving the folfirinoximab chemotherapy. Excellent response on the recent CT scan, which is just a couple of weeks ago. He also underwent the colonoscopy just last week, and it didn't show any evidence of the disease locally. His last CA level was 4.5. So our last 9 years, the patient was diagnosed in 2007, and now we are in 2018. In the last 9 to 10 years, with 9 years of metastatic disease, and he has been subjected to two times. He has the local therapy for the liver lesion, and including one-time embolization for the one of his liver lesion, and two time he has the metastatectomy for his lung lesions. But in spite of all these and the 5 lines of chemotherapy at different times, the patient is performing very well. He is maintaining his quality of life, good performance status, which is ECOG PS1, and he's carrying out his usual activities. So discussion and conclusion from this case is that the resection of the liver metastasis result in cure rate 50 to 60%. As we have seen in this case, that all the subsequent CT scans and all the images didn't show that his liver lesion is recurring back. So the next is the 5-year survival rate post lung metastatectomy is between 24 to 64%, which is high. So any patient who is going for the resection of the lung lesion, the NCCN recommends that the chemotherapy should be offered since the relapse rate is very high. Thank you very much.